All right, you can probably get about 20%, 25% of the questions just if you know how to read an MRI or a chest x-ray or know which lung sounds you're expected to hear. So it's pretty useful to go through all of these. So I guess here we have 15 different ones, and by the end, hopefully all of these fall into relatively clear categories. So on the left, we're always going to have a normal one, and on the right, we're going to have our pathological x-ray. So again, we're looking at the costophrenic angle. We're looking at a diaphragm that is relatively, that's not particularly flat. We want it to be, relatively translucent, but not overly black. These are all things that we're keeping in mind and making sure that the esophagus and the trachea are straight and not deviated towards one side or the other. So with that in mind, let's go ahead and take a look at this. I see a flat diaphragm. I see very radiotranslucent. This is emphysema. Here I see that the trachea is kind of at an angle. It's pushed over to the right. This is a little radiotranslucent. This is likely a tension, specifically tension pneumothorax, so much pressure that it is pushing the entire mediastinum over to the contralateral side. Keep in mind that atelectasis might pull potentially the trachea over to one side or the other. Here, potentially this could be a pleural effusion, but this is likely lobar pneumonia. Here, this one's kind of a giveaway. We've got a P for pancostal tumor, but we just see this coin lesion up towards the apex of the lung, and that's a clear giveaway there. Looking at this, we see a little coin lesion, so we're almost certainly looking at a lung cancer. In addition, I see unilateral, not bilateral, hilar lymphadenopathy. If it was bilateral, it could potentially be a sarcoidosis or tuberculosis. It could be a cancer if the cancer spread to both sides, but this is likely going to be just a unilateral side. And noticing that we have a central cancer, it's likely to be a small cell lung cancer rather than a non-small cell lung cancer. So we'll go ahead and say oat cell or small cell lung cancer here. Same general idea here, but now I see that this is not central. So remember the S was for small cell and S was for squamous cell. And so this is neither of those. It's a non-small cell. I'm assuming that this is adenocarcinoma just because it's the main one. We don't really know at the end of the day. You're not going to just go off of the chest x-ray. This is just definitely going to help you out, but you should have other, they're going to mention that it's a woman. They're going to mention that it's non-smoker, something like that. Maybe that it's crass or EGFR positive. Here we see this nice honeycombing pattern, this reticular opacities. This could be atypical pneumonia, also known as interstitial pneumonia, could be pulmonary fibrosis. I don't really know. I find it very difficult to tell. I think if you can get it narrowed down to those two, you're probably in good footing. So this is probably a pleural effusion. Pleural because it's on the periphery and it's just so damn opaque that it couldn't possibly be couldn't be anything other than just massive amounts of fluid. They're probably lying on their right side, which is why, that'd be my guess for why it's pushed over to there. I don't know, maybe it's pinned up for some reason as well. This, I'm guessing, is just a pleural effusion, but someone's laying down, or gravity is now bringing this down to the inferior portion of the lung. Here again, not really a trick question, but I'm not above putting the same thing twice. Emphysema is really common. You guys should really know what it looks like. This is a very flat diaphragm. We have a very expanded rib cage, so this barrel chest, and again, this is a little bit radiolucent. So this is also going to be emphysema. Again, I think we've got another emphysema. Wow, I really loaded you guys up on emphysemas. Again, very radiolucent, relatively flat emphysema. Here, this always kind of looks a little bit like pulmonary fibrosis, but here you have this diffuse, not slightly homogeneous, but it's just a little bit like fuzzy, a little bit blurry. This is ARDS, acute respiratory distress syndrome, looks a lot like pulmonary fibrosis, but I think it's really good to differentiate the two. Here we go again. So notice this is ARDS. This is a pulmonary fibrosis, potentially an atypical pneumonia. Here we see highlighting of the hilar. So this could be a lung cancer, but it's on both sides. There's a little bit of reticular formation opacities, this honeycombing kind of. I bet if I saw an axial MRI, we could see it better. My guess would be tuberculosis or sarcoidosis. Let's go with sarcoidosis. All right, here we're seeing this giant thing over there. Notice that this is radiotranslucent, so this is this must be a pneumothorax. Yeah, this would be a pleural effusion if it was a little bit more opaque. Here we go. This is a great example of something that is opaque. This is going to be a pleural effusion. All right, let's go and see if we can get all of these. First one's normal. I'll give you that one. Here we have lobar pneumonia. Here we have a adenocarcinoma or some sort of, if you get points, if you can just tell that it's a non-central lung cancer. Here we're going to see these hazy, blurry infiltrates. This is ARDS. Here we have the hilar lymphadenopathy. I see kind of reticular formation, maybe sarcoidosis. Over here, let's say atypical pneumonia or pulmonary fibrosis. It's really hard to tell which one, so we'll go with either. Here we have a pleural effusion, which gravity has brought down. Here we have this large expanded rib cage. We have this flat diaphragm, and it's relatively radiotranslucent. This is emphysema. Here I have, again, this is going to be another one of those atypical pneumonia or interstitial fibrosis, honeycombing. You can tell, as well with the axial MRI. Here I have a pleural effusion, but I think someone's just lying down on their side. Looking at this one, we have a flat diaphragm. Notice this as well. You see this in a lot of them. This is just your bowels. This is just your stomach filled with gas. You're going to see this in a lot of different things, and it's nothing to worry about too much. Not to worry about at all, right? It's below the diaphragm, so it's just, do not confuse this with a pathology. Anyways, looking at this again, we tension pneumothorax because we see that the trachea is shifted over to the right, and this is a little bit radiotranslucent compared to the other side, which means more air is in here, pushing everything over that way. Here, flat diaphragm, very dark, emphysema. Here I have a coin lesion. I have a hilar lymphadenopathy. It looks unilateral. I'm going to go with a lung cancer, non-central one. So it could be squamous, could be small cell. Let's go with small cell. And over here, again, gosh, am I really putting that many emphysemas? I think I see a flat diaphragm. I see another radiotranslucent. Yeah, that's emphysema. And then the last one, again, the P is kind of dead giveaway, but this apical tumor is going to be a Pancoast tumor. All right, so percussion, if there's more air in your drum, it's going to be louder. So emphysema, pneumothorax, it's going to be hyperresonant. If it's a little bit more solid, or if the air is not there, atelectasis, consolidation, effusions, fibrosis, less air or more fluid means it's going to make less sound upon percussion. Fremitus, though, it's not, maybe it's hyperbolic to say it's the opposite trend, but we're looking at the vibration of the chest wall. And sound travels better through a solid, through a liquid, than it does through air. So most things will get quieter with fremitus, but consolidation, where I have tons of exudate in my lungs, like a lobar pneumonia, will make it denser, and that will make it louder. Normal breath sounds. So I think we went over this recently, but let's just take a listen. Notice up, down. That is our bronchial breath. So this is, you're normally going to hear bronchial breaths if you go ahead and listen to specifically the trachea. You could potentially hear this. But, if someone has lobar pneumonia or something like that, or a pleural effusion, then you might just hear it in other parts of the lungs, where typically you should only be hearing vesicular sound. So let's contrast this with a vesicular sound. Up, quick down. Up, quick down. So that's vesicular, that's normal. Again, bronchial is technically normal as well, but it's only normal in these two regions, not really anywhere else. Vesicular should be here, but not if you have pneumonia or pleural effusion. So an adventitious sound is one that doesn't really belong there. That's a response to some sort of stress. So wheezing and rhonchi kind of go together. This is for obstructive, and it's going to be on exhalation. Crackle and rails is going to be when there's fluid in the lungs. This is mostly an inspiration, and a pleural friction rub is going to be painful, and it's going to be particularly loud. So wheezing is the main one. Rhonchi is a little bit outdated, but obstructive, inflammatory, air has, there's turbulent flow, has a hard time getting through. You could hear it on expiration and inspiration, but it's going to be a little bit more on expiration usually. And rhonchi is technically like a deeper, lower snoring, and wheezing is going to be a little bit higher pitch. So let's take a listen. All right, contrast that with wheezing. All right, rails and crackles. So it's going to be a little bit more short and explosive. Crackles really is a good name for it, bubbling, rattling, clicking. It's going to be worse with inspiration. This is when you have fluids in the lungs, pneumonia, also heart failure, of course, specifically left-sided heart failure. So we have two different types, high-pitched, kind of like the wheezing, and then coarse, the low-pitched, kind of like the rhonchi. So this is where this is going, the alveoli or the bronchioles are closed, but air moving through can pop them open, pushing them open. That pushing of the open, kind of like if a valve in the heart opens, can potentially make a sound that you could hear. So let's listen. Crackle, crackle. Crackle, crackle. Okay. All right, let's listen to this one. Okay. And then pleural friction rub. So this kind of sounds like, I don't know, I thought it was the sound that, makes when you walk on fresh snow. A couple different things can cause this: pulmonary embolism, pleurisy, which is really inflammation of the pleura. A lot of different things can cause this, and pleural effusion. So it's going to be a really sudden, intense, sharp pain, specifically upon inspiration. And again, it's that when the lungs expand and contract, the pleura would want to rub against each other, which would create a lot of friction, would be painful, would make a lot of noise, but usually the pleural fluid stops that, but not if there's inflammation. It's similar to a pericardial rub when you have pericarditis. The difference is if you hold your breath and the pain persists, then the sound persists, then you're dealing with a pericardial rub. It's a heart issue. But if it stops when you stop breathing, then it must be a pericardial rub of the lungs. And it's going to be particularly loud considering that the pleura are on the periphery, and that's where auscultation is occurring. So let's listen. All right, and then stridor, specifically if you get something stuck in your trachea, your upper respiratory tract, or if it's a child that has croup, you're going to hear this. And all of these together. I think we have our rhonchi. Let's take a listen here. And we have our fine crackles. Let's listen here. That's our wheezing. Let's listen here. I think that's our rhonchi. That's our coarse crackles. We know this one's croup. Yep. And a pleural friction rub. Oh gosh, what a symphony.